So I'm Matthew Hill. I'm Head of Insight Evaluation and Research in the Q team. Great to see so many people here today on the workshop. This is one I've really been looking forward to for a while. We're very lucky and grateful to be hearing from Health Innovation Wessex and their new evidence-based model to support de-implementation. Such an important topic, really an area where we need to do better if we are going to achieve the ambitions across the UK and Ireland. Before I introduce our fantastic speakers, I'd like to take a couple of minutes just to make sure that everyone's got what they need to get the most out of the workshop. So if you could just move the slides along, Andrew, that would be great. So firstly, for those who are not yet part of our Q community, but are working and reside in the UK and Ireland, we'd absolutely love you to join us. We're a large and diverse community reaching across the UK and Ireland, and collectively we collaborate to improve the safety and quality of health and care. And you can see a bit more on the slides, info about Q and a link to the webpage where you can join Q. I think that'll also go in the chat as well. Q is free to join. We just ask for kind of energy, enthusiasm and commitment, and you gain a lot through all of the connecting, learning and sharing with other members. It's really rich community and I'd really encourage you to sign up. In terms of closed captions, actually, yeah, if you could just move along one more slide, Andrew, that'd be great. If you'd like them displayed, please click on the bottom of the screen under More, where you'll see CC. Clicking this gives you access to the closed captions. If you do have any technical issues, you can ask for help in the sidebar and we'll do our very best to help you. And we are going to record the session. We'll be sending a follow-up email with links to the recording, some useful resources, and the slides. We will send the slides, so you don't need to ask that in the chat. Okay, so that's everything that we need to get the most out of the session. I'm delighted now to introduce our speakers from Health Innovation Wessex first. So we're joined by Philippa Darnton, who's Director of Insight at Health Innovation Wessex. Having led a team to deliver over 100 independent evaluations of innovations in healthcare, including digital solutions, her work's contributed critical insights to enable decisions about what innovation benefits patients and our healthcare systems, and crucially, how to implement it well. We're also joined by Andrew Sibley as an evaluation program manager on mixed methods at Health Innovation Wessex. Andrew brings a wide range of expertise in using advanced quantitative and qualitative methods to support real-world evaluations of innovation. We've got Emma Williams, who's the Associate Director for Strategic Partnerships and Business Development at Health Innovation Wessex. Emma's worked for almost 30 years within management and frontline roles across health, social care and the voluntary and community sector. And Patrick Arnold is an Innovation Adoption Programme Manager with a focus on primary care. So Patrick's passionate about finding ways to enhance the great work already being undertaken in primary care in Wessex and nationally to improve healthcare practices for clinicians, non-clinicians and patients. And as well as the four colleagues from Health Innovation Wessex, we're also really pleased and grateful to be joined by two colleagues from NHS Dorset. So we've got Ellie Venton, who's Senior Programme Lead, and Ellie Pollock, the Service Improvement Officer at NHS Dorset. So a great group of speakers that we're going to learn a lot from for the rest of the day, but that is more than enough from me. I'm going to hand straight over to Philippa now to take us through the rest of the session. Thanks.
Thank you, Matthew, and welcome everybody. Thank you so much for joining us, and thank you to the Health Foundation and NHS Confederation for hosting us today. So as Matthew said, this session is all about de-implementation, and it's sharing with you some work that we've been doing for several years now in Health Innovation Wessex to really think through how we can provide support to health and care systems in taking on what is often a really hard task. So to bring in innovation and to make room for that by stopping or replacing previous ways of working. We've been particularly looking at this in the context of innovation. And the work's been done by a whole team of us. So I'll just make a quick mention of some others in the team. Dr. Jackie Chandler, Cheryl Davies and Jenny Curtis, who have contributed to this work as well. So I'll take us into the session. Next slide, please, Andrew. Just to give you an idea of the plan for today, we've got some presentations for you, but also want to spend a lot of time giving you the opportunity to share with each other your experience of working in this space. We want to describe to you why de-implementation really does matter, particularly in the new strategic and policy context for the NHS. Explain to you how you might support de-implementation in your work. We're describing a model that we've called the 4 pillars of de-implementation, which we hope will be of interest to you. And our colleagues from NHS Dorset will describe a case example of how they've used the model in their work. We'll have some breakouts and opportunities for questions and answers, so really look forward to hearing from you all as well. Next slide, please. So I'm going to hand over to my colleague Emma now, who's going to just describe to you the work that we do in the Health Innovation Networks before we get into the specific topic of de-implementation. So Emma, over to you.
Thank you, Philippa. And yes, welcome everybody. Thank you very much for joining us today. So I'm just going to briefly touch on, some of you may already know about the Health Innovation Network. We are commissioned by the Office for Life Science, and we're also commissioned by NHS England. And Wessex is one of 15 local organisations which are based across England. And we bring together, so we're almost like a facilitator for bringing together NHS, industry, academia, and the third sector, really to drive health innovation across the NHS at pace and scale. And that really is helping our health and social teams to find, test and implement those new solutions at scale that help meet the NHS greatest challenges and also to support economic growth. Some of the figures down here are representative of the Health Innovation Network's impact across the last periods from about 6-8 years. So we've helped over almost nearly 5 million patients to benefit from national programmes, around about 340,000 hours of healthcare staff team capacity has been released by using innovations and innovative practice in a different way. As I said earlier about the economic growth, we've helped innovators to leverage income to support their companies so that they can develop their innovations. And we've helped to secure 11,000 jobs which have either been created or safeguarded to support those companies. And as a return on investment for our government, it's seen that Health Innovation Networks provide a 3-in-1 return on investment on the work that we deliver. So if I could go to the next slide, please. So as I say, we are one of 15. So we call ourselves the local change with national impact because we work across England. So we work as a network of networks, and we're that bottom one there at the base of the map. And as we said, we're really there to support the NHS workforce, helping to reduce demand, alleviate burden of wait times, and really help to drive that economic growth and innovative practice in the workplace, and really helping to implement innovations and support our partners to do that. Andrew, if you could move on, please. So just as a role, just to say, as a network, we help to find, test and implement. So we support innovators in that. So we look for innovations and innovators, so developing from good ideas into scalable solutions and helping them to test those ideas. And then we also support in testing in the real world, and then helping teams to implement and help to support their work. And as we said earlier, LEs, the 2 LEs will be able to tell you how that's looked. We do this to improve the health of patients. We do this to help save health and care teams the time and the use of the resource, and really being able to focus on the things that mean the most to them, which is delivering care to patients and support to people living in the community. We also help to drive economic growth. And obviously we're focused on those 3 strategic government shifts, which are treatment to prevention, hospital to community, and analog to digital. So if we could just move through. So we can't do this in isolation. So it really is, whilst we work primarily on innovation implementation space, it is all about that partnership across the innovation ecosystem. So with our colleagues today, but also we work with the health, life sciences and industry partners. We work all across health and care, and we work across academia. So you can see that pathway from early research right the way through to scaling and sustaining and improving. And some of the partners that are really key partners in that delivery with us. So if you'd like to move on, please, Andrew. And just a little focus on Health Innovation Wessex. So here we are at the bottom of England, and yes, we cover Dorset, Hampshire, and a little bit into Wiltshire. And we really do focus on supporting innovators, potentially from commercial, clinical, academic, or other backgrounds, to accelerate the development of a solution which is going to reach patients faster and is going to meet the needs of our NHS. Along last year, we supported round about 284 innovators to develop their ideas, whether that's from a really small idea right the way through to implementation. And we help along that, supporting along that journey, as I say, really to help support better lives and better outcomes for patients and to support economic growth. So if we move on to the next slide, I think I'm going to be handing back to Philippa to talk about the strategic context.
Thanks, Emma. And just very briefly, I wanted to cite some key plans and policies that are describing the government's commitments to the health and life sciences and that ambition to work in a new and different way. These clearly emphasise the importance of de-implementation and being able to de-implement in a managed and considered way that's really going to help delivery of the plans. So the Fit for the Future 10-year health plan, as you'll be aware, is very focused on realising 3 important shifts from hospital to home, from treatment to prevention, and from analogue to digital, and is very likely going to require de-implementation of existing ways of working, introduction of new evidence-based practices. So very critical that de-implementation is done successfully and efficiently. The Life Sciences Sector Plan puts a firm emphasis on the importance of uptake of innovation to achieve the government's ambitions. And of course, those plans are being delivered through a strategic commissioning approach articulated through the model ICB blueprint, which is really encouraging commissioners to be bold in rearranging and potentially decommissioning services to secure the best outcomes for the public and the best quality of services. So you can see how all of those plans, strategic objectives, really require us to know how to de-implement and have tools and resources to do that well. So that leads us nicely on to the main body of the session then, and I'll hand over to Andrew. Thank you, Andrew.
Thank you, Philippa. Afternoon, everyone. So to continue through Philippa's journey here on why does the implementation matter and what is it and how can we define it? It's an interesting area in the research field. In terms of defining, Walsh Bailey have put forward a definition in 21 that de-implementation is about the discontinuation or even abandoning of practices that are proven not to be effective or less effective or less cost effective or indeed harmful. And this is an important definition, I think, to put us in the right headspace for the rest of the discussion today. And there's a further expansion of this definition and more nuanced view on de-implementation from Norton and Chambers, who considered 4 different R's, four types of de-implementation that may be going on. Firstly, you may be attempting to remove, such as imaging tests for uncomplicated back pain. You may be attempting to restrict access to medication. Or you may be trying to reduce unnecessary procedures. The procedures may work, but you may be trying to do slightly less of them for resource-related issues. Or in fact, you might be attempting to entirely replace an old way of working with a new one. And I think this is a really we found this particularly helpful and a really important first step for consideration in de-implementation discussions. What kind of are you planning to be engaged in? So continuing on, why does de-implementation matter? The research literature suggests it does. It can free up resources for better and more effective care. There's evidence out there at the moment that, particularly in the US, where they've estimated that between 10 and 30% of healthcare practices have minimal to no benefit to patients, which of course is very alarming to hear that. And it has spawned various large national scale interventions to attempt to look at this challenge. It also has a cost related to this. In the US, it's estimated to be a multi-$100 billion challenge of low value care costing that much to the US health system. In the UK, there are some indications of the cost of low value care. The 2015 Carter review on productivity identified $5 billion in unwarranted variation of services. And when the overall NHS budget of approximately $250 billion is considered, then even a conservative guess at 1 or 2% of that budget being spent on low value care indicates that low value care could be a £1 billion challenge to tackle. But importantly, it's not just about cost savings. This has wider implications about evidence-based modernization, and it's about the replacement of the old with better and more effective ways of working. Secondly, de-implementation can be very supportive of removing harmful or outdated practices. And there are many patient safety considerations from this, and that's often been the center of two large initiatives that have gone on. Firstly, in the US, the Choosing Wisely initiative, which started first in the US and has later spread to other countries, where lots of surgical procedures or laboratory procedures and tests have been re-examined for how harmful they may in fact be based on evidence, and thus be incentivized to be removed. And in the UK, the evidence-based interventions program have been looking at surgical procedures and which ones to potentially de-implement since 2019. So some very large national initiatives ongoing into this area. And interestingly, in a review, a summation of these initiatives by Anderson in 2022, they noticed that the de-investment mechanisms of setting targets or zero tariff payments was met with mixed success, and that there were in fact still some significant challenges in terms of attempting to disincentivize and de-implement old ways of working or less ways of working that had low value. And some of those involved the complexity and the practicalities of stopping. And also importantly, the de-implementation offers an opportunity to support alignment with evidence-based practice to ensure that the latest care really reflects the latest research. And so de-implementing opens up that opportunity for knowledge to be translated into care. Importantly, deciding what to stop is a prerequisite for the model, which we'll describe shortly. In our context, we work with the service commissioner or service manager to make that decision about what innovation they would like, what way of working they would like to stop, and whether or not a new innovation will be replacing that. But it's an important first step and first part of the model. As a practical example, I put this one in to describe perioperative testing. This comes from the Smith and Haynes paper, and describes some perioperative testing as a way for healthy patients to undergo low-risk surgeries. It's long been a standard practice, but researchers identified limited clinical benefit, and so these tests often led to unnecessary follow-up procedures and increased patient anxiety. and higher health and care costs. So recognizing this, the Choosing Wisely campaign, launched in 2012, targeted low-value practices with de-implementation such as this. And as a notable example of successful de-implementation that occurred in several US health systems, hospitals eliminated this type of testing for low-risk procedures for cataract surgery and hernia repair. And this shift was supported by specialty societies, and they issued clear guidelines discouraging this unnecessary testing. And the benefits of this change were substantial. Hospitals were reported significant cost savings by avoided redundant tests and reducing downstream care triggered by false positives. And patient safety and satisfaction was improved as individuals were spared from unnecessary procedures and delays. Importantly, studies confirmed that eliminating these tests had no negative impact on surgical outcomes and reinforced the safety of the approach. And moreover, this initiative fostered a cultural shift towards evidence-based care, encouraging clinicians to critically evaluate long-standing practices and freed up resources for staff and equipment for higher value care. And so this case illustrates how a thoughtful evidence-based de-implementation can enhance care quality, reduce waste and improve patient outcomes. As another quick example of this was a real-world evaluation we conducted at Health Innovation Wessex, looking into the challenges of replacing drying and storing of endoscopes in a hospital, which is a very busy part of the hospital, very reliant, interdependent part of the hospital for surgical procedures. And the recent evaluation of Plasma Typhoon, which is a replacement device to dry and store endoscopes faster than the previous way of working, was demonstrated to be faster and greener and more cost effective. And interestingly, we were able to estimate that within one financial year, £107,000 was saved for that department. And this was a very helpful demonstration of how the financial value can be found. However, because interestingly, part of the evaluation identified that they were running the old system alongside the new system at the same time. And this phenomenon meant that the financial benefits and the other benefits available of the innovation were diluted by running the two things at the same time for an extended period. So there could have been more savings, and this goes to highlight some of the interesting phenomena that go on in this space. There were also two barriers we identified. First, in the adoption of this new technology, staff were hesitant to fully embrace the new system. And secondly, the old system, the older drying cabinets, were expensive and difficult to remove, costing potentially tens of thousands, and presenting a dilemma for financial directors in what to do in terms of sticking with what they had or adopting the new way. Importantly, it was very clear that we needed that there still were some remaining challenges from this work, and that there was a lack of clarity about how to de-risk the process and develop a managed process and develop a practical framework to support de-implementation and to ensure that the full benefits of the innovation are seen. So at Health Innovation Wessex, a team of colleagues developed the 4 pillars of de-implementation model. And this was based firstly on our experience of adopting and supporting the adoption of many innovations over many years, but also a careful look through the frameworks and theories that exist currently out there in the research literature. We acknowledge, as does Grimshaw in his 2020 review, that there are limited frameworks for de-implementation in healthcare. And importantly, we identified a lack of practical guidance to support innovators and service managers on the ground. And through our review of these frameworks and through our experience, we drew out key concepts to operationalize our model. And importantly, our model is aimed at supporting service commissioners and service managers to de-implement once they've made a decision, and once a decision has been formed about a way of working they would like to de-implement, a way of working they would like to restrict or replace, remove or reduce. So we've organised the research concepts that we came across and our experience into 4 pillars, 4 areas that we would work with innovators and service managers on. The first being to validate and assess the work that they bring to us, the decision that they've formed, and we would do this by baselining the current activity to ensure and validate that it's the right thing to reduce and restrict or remove or replace. And to understand what activity is currently happening and what happens if that activity is stopped. And to be really aware of the current as-is situation and predict the impact of stopping the practice. So there's lots of evidence gathering, lots of consideration about cost effectiveness, about patient safety, patient feedback if it's available, really to build the case and enhance the case for change and to really clarify the purpose. Importantly, understanding the context is vital, and to ensure that the support is aligned and coordinated, particularly if you're planning to de-implement and implement something new at the same time. The second pillar is about assessing those consequences and assessing the impact. So having confirmed the case for stopping an old way of working, this pillar explores how the process of de-implementing the old way of working will affect staff roles and patients and their care and workflows and equity, access and outcomes, and how people might feel about the change in ways of working, and what are the emotional, behavioural and cultural impacts of doing so. And to do this, you may engage in logic model activity or process mapping to understand what's going to happen. What sort of ripple effects will your innovation, will the action of taking out a way of working have? You may want to consider staff views. They may have ties. They may have a brand effect with the previous way of working. They may feel very strongly about that. The public and patients may have a view and they may object or they may welcome this change, but nonetheless, understanding that and the potential impact is important. And a potential output of this part of the model is to develop an assessment of this impact on people, processes and services. Thirdly, having worked through the assessment with the service managers or commissioners, this is an opportunity to really understand what behavioural, what enabling strategies might be required to move forward. And we propose that there are 3 different types of strategies to consider. One, behavioural and communications. This is backed up by the research in this area that there are some interesting psychological differences between implementing and de-implementing, brand effect being perhaps one of them. And being very clear on how staff can, of course, be a fantastic enabler, but also a potential barrier to change. And how will this change be framed? How will it be presented to the various different audiences and people that it will affect? The second strategy area is about policy and processes, and really understanding what the change that you're proposing, the way of working that you're going to stop or replace or restrict, and what processes will be affected by those. And thirdly, to consider infrastructure, equipment and facilities. And interestingly, in a recent overview of systematic reviews about de-implementation by Keane in 24, did identify infrastructure, that being staffing and equipment, as a really key consideration, and some of the best and most successful de-implementations have considered and managed this factor. Finally, from those strategies is an opportunity to translate those into operational plans. to manage this change with clear steps and responsibilities and monitoring to ensure the implementation is sustained. An important opportunity here is to stop the resurgence as a phenomenon that occurs in this space, and special attention to this is very worthwhile doing to avoid backsliding into the old way of working. So time spent on these operational plans will de-risk your de-implementation plans and will hopefully ensure a managed approach moving forward. So how do we go about this? How do we go about operationalizing these pillars? Well, this is one of our most exciting parts of the model, we feel. It's the implementation canvas. It is an example of operationalizing these research concepts into a practical tool. It's a series of Socratic questions that encourage open-ended inquiries to help foster critical thinking and explore complex ideas in a complex environment. And working through, you'll recognize the pillar columns there, but working through the first, you're going to try and attempt to get to a decision point about which kind of de-implementation you're involved in. The second column, you'll work through these questions to get to a review point. And the third, to an enacting point, to share the strategy with key stakeholders and build consensus. And finally, you'll be monitoring to maintain regular check-in points with key stakeholders to ensure plans remain on track and the older ways of working do not return. And of course, the key output of this experience, of this detailed engagement with the service managers and leads will be a de-implementation strategy and operational plan, a working living document that you can use to move forward. As a takeaway message, through our work in this area, we've become aware that de-implementing health services is not just a technical challenge. It really is a social, behavioural, and potentially an emotional one. And if nothing else lands today, it will be wonderful for you just to consider that going forward. And as we feel, it's quite important. So just finally, some final thoughts from me are to engage as much as possible in the planning of the implementation and the consideration of the old ways of working, and to turn that into a managed and planned approach so that the change can be sustained, and to engage early and engage widely, and communicate clearly, really explain the why behind the change, and take it beyond a technical challenge into to consider all the facets of how people may view the change. Champions, much like implementation, will be key here for de-implementation, and the identification of respected individuals will almost certainly help you in this space. And as will being patient, particularly because change can take time, attitudinal change can take time, and keep monitoring to prevent those old ways of working returning. So thank you for listening. If you have any questions on this topic, there's an opportunity for questions shortly after a case study, and I'm very happy to hand over to our Dorset colleagues, Ellie Benton and Ellie Pollock, and we'll move the slides on.
Thank you, Andrew. We've just been invited to come along today to showcase what we've been doing in Dorset, because I think we're one of the first people to use the pillars and to use the model, and we found it really helpful. So we thought it would be useful to show everyone else how we used it. I think we probably had quite a bit of learning along the way as we were going. We started our project slightly before we got in contact with Health Innovation. So as Andrew was saying, we had kind of made our decision already, but being able to have a model to put it all in place and to put all our thinking onto paper so everyone else could see it and was able to review it as well was really helpful. Andrew, can you just go to the next slide, please? So we have we had a website in Dorset called Maternity Matters. This was made about 7 years ago, and it was made with patients, with staff. It's a really co-produced project, and it had been a really successful website for quite a few years. It was a real big brand in Dorset. There was lots of posters all around GP surgeries and pharmacies. Everybody knew the logo. However, although the website looked like it was working very well because of this strong brand, in the background we had quite a few issues with it. So when it was made to be, it was a point in time, and the website had become very wordy when it was developed. So there was a lot of text on there, whereas the design principles now have moved to be more images and tiles and very easy read. So the website itself was quite hard to navigate now, and took a lot of time to get to where you needed to be. It also didn't have a translation feature on there, which we all know now from the Embrace reports in maternity, that we need to be able to offer translation and easy read options. When it was put in place as well, quite a few people unfortunately were given the passwords of the back end of the website to be able to make changes, which at the time obviously we thought was a good idea. Everybody could be involved. However, the governance wasn't tight enough around it. So people were suggesting ideas. It wasn't being confirmed with the whole of the system that everybody agreed with the ideas. Things were being changed on the website. It just got a little bit out of hand, to be honest. So we needed to try and rein it in. But because of all of these reasons, we decided actually it might be a good opportunity for us to stop and rethink what we were doing. So luckily for us, Health Innovation had been working with Healthier Together, which was a website that was developed in Hampshire. It's children and young people's as well as maternity and neonatal. And we were working with them to see if we could purchase their app that they have there for a triage system. So we continued the conversations around the website that they had as well. And actually the website itself was managed by a central team, and all of the content that was on there was reviewed regularly by this national team, and also had a Royal College of Midwifery on there as well. So that would take away the reviews that we had to do in Dorset, which was really clinically quite heavy, and we didn't have the resource to be able to do it. The website also had a built-in translation option and easy read. So it really became quite clear that that was where we needed to be going, especially once all the ICB changes were announced. We knew that we wouldn't have the resources as an ICB to be able to maintain the website. So as I said, we'd kind of made the decision that we wanted to move over to Healthier Together. And then we were able to start using the tool, which Ellie Pollock will take you through in a minute. What I just wanted to say was that my particular concern was the behaviours of the staff. So those that had been using the website or had helped to build the website over the years. I was really concerned that quite a few of them did take it quite personally when we said we were going to de-implement it, which I could understand because I'd also been involved in it as well. So I did understand their feelings. But having used the tool, it gave them the opportunity to see all of the reasons behind it, gave them time to input into it. We developed some FAQs based on what we went through in the pillars. We were able to put the communications out there nice and timely and over a period of time. We wanted to ensure that we retired the website with dignity and celebrated all the work that had been done. So I'm pleased to say that we have successfully switched over to Healthier Together now. We have completely turned off maternity matters, and we haven't, so far, fingers crossed, had any big output and big fallout from that. It's gone really well, it's gone really smoothly, and I would say this is down to the nice clear planning that we've been able to do. So I'll hand over to Ellie now, and she can go into the detail of how we used it.
Great, thank you. Thank you, Andrew. Thanks, Ellie. So yeah, there's lots of positives we can draw from this experience, but I'm just going to outline a few of the things that we came across as we worked through this. So as we began to use and really populate the de-implementation canvas, although we had already outlined some of those key deliverables and enablers for the project, what I think the tool really provided was that structured way to test and challenge the quality of our early thinking. So it prompted us really to revisit our baseline evidence and go back through each phase to strengthen the sequence of our actions and really clearly define dependencies, and to check that our approach remained sustainable as we progress through. I think a good example of this in the scoping phase, so really that case for change, was the use of the baseline evidence. Although we started to look at what this looked like and we'd made the decision, as Ellie alluded to, about moving across, we needed to strengthen what that looked like. So we used some of our Google Analytic report data to understand the activity on our current product, which was the Maternity Matters, and really included that information around things like our most visited pages and what our service users liked, and use that as an insight to shape the proposed content changes for Healthier Together. But we went further with that. So what the tool encouraged us to do was to think how we could go further and support that sustainability, that so what piece. So it led us to share information with Healthier Together team and plan to repeat analytics in a few months after the redirect takes place, really to form part of that evaluation and help inform any ongoing recommendations and support that long-term sustainability piece. So another key benefit of the tool was the way it helped to shape the scope of the project from the outset. It provided a structure to our documentation and strengthened our approach to our sustainable practices and processes. It guided our communication and engagement planning and also supported the development of our strategy that we pulled together. And that really ensured we had the right people involved, making sure our stakeholders and service users were informed and involved in the process early on. And one of the bigger things that stood out for me was around the behavioural considerations. So the canvas alludes to those and really encouraged us to think differently about how we design our communications, making sure that we're genuinely tailoring and creating meaningful documents to inform our audience. So as Ellie alluded to, we developed a set of FAQs, and not only did it share key messages, but it also directly responded to questions raised through earlier engagement with staff and service users. In the end, we ended up producing 3 versions of that in different formats to make sure they were shaped to behavioural insights, but also tailored to the different readers and audience. And alongside this, we identified leads within each of our trusts to help champion the change and help to cascade that messaging consistently across teams, which had some good feedback, recognising that they were trusted by their colleagues in the trust. So it was a really good move to involve people to help us with that. So it continued to support us throughout the delivery, shaping and designing each of the project phases, and helped us with decision making, clarifying the deliverables, and ensuring that the behavioural considerations and insights were embedded throughout. We also used it to structure agendas and guide discussions in our delivery group meetings, and it supported the ongoing development of our project documentation, making sure that it was that consistent reference point for quality assurance, and making sure that we used it to review our progress against our original plans and timelines as well. And importantly, the model strengthened our sustainability planning and prompted us to consider change request processes, escalation routes, and also the business continuity needs after the project finished. So it helped us to think more broadly and reflect on how we might approach things differently. And ultimately, it enabled us to go further with our original plans and deliver a more robust and well-considered project. So if we move on to the next slide. So I've picked out a few of the key things. Oh, yeah, thank you. On this next slide. And really, I think I've probably already said it, but the tool became that accessible resource for us, and we continually returned to it throughout the project. It supported that day-to-day delivery, helped to expand our thinking, and also ensured that consistency by enabling us to revisit it and build on that earlier work as the project developed and evolved. So the experience was further strengthened by our regular meetings with Health Innovation Wessex colleagues, who really acted as that critical friend by providing that check-in challenge at each stage. And I think gaining that external perspective was really invaluable for us, particularly as we're so close to the service level detail of maternity and neonatal. I think it can sometimes lead to things being overlooked that could be a potential barrier or risk. So having that external check and challenge was really important and vital for us. And overall, the tool improved our quality assurance processes and documentation needed for the successful and timely delivery of this project. So really, I'll end with a thank you to the Health Innovation Wessex team for their support and advice throughout the project. It's been really invaluable and really helped us to think differently about how we may de-implement things in the future. So I'll hand over to Philippa for any questions.
Thank you, Ellie and really nice to bring it to life through your example. So we will move to the Q&A session now. Two options for you. If you'd like to come on screen with your question, please raise your hand. If you wish to put a question in the chat, please do so. Emma will monitor the chat and bring through some questions, and then I'll field those to whoever I think will be able to help with you. I wonder though whether I start with the question from Matt. Matt, would you like to ask that out loud? Shall I bring it through?
Yeah, sure. No, I'll jump back in and use my prerogative as introducing the session. So my question, it was a fantastic presentation, Andrew. I guess I was particularly interested in that point you made that although a lot of the principles are shared, de-implementation is not simply a kind of mirror inverse of implementation. You obviously set out the pillars and process to go through, but I was wondering if you had any thoughts or reflections on whether the skills that are required for de-implementation are different to implementation.
Thank you. Thanks, Matt. I'm sure there's other views on the call as well with our QI colleagues here who will be very well experienced in this space. My thoughts drift to the differences in skills. I haven't seen research per se done on that, but there has been in terms of comparing de-implementation and implementation activity. But there has been a look at it through the lens of strategies. The Sara Ingvarsson in 2022 did a big review of de-implementation strategies and noticed that there were lots of similarities, but also a few differences. And that leads me to my thought really on that if you are de-implementing, you're likely to be attempting to implement at the same time. So the strategies such as redesigning services and being very good at that would be a positive and be a skill set that would be very valuable. Also, I was thinking about this idea of dignity and that Ellie mentioned and retiring services rather than hard stops. And I think there's some framing and communication skills there that are needed to retire services with dignity, to celebrate their benefits and the successes they brought, but recognize that times have moved and there's faster, cheaper, and more effective ways of doing things.
Thank you, Andrew. Emma, are there any questions in the chat?
Yeah, there's a couple of questions. Is the tool free for everyone to use? And then also we have is the canvas easy to use? Do you need specific skills, knowledge in QI? Can you do it without external help? So those are the two questions. I don't know whether who you want to direct this to.
I'll start, Emma. So we're really wanting people to try out the tool. You'll notice that there is copyright on the tool, and that's just to protect the IP around this, but we're really keen that it's used. If you're interested in using it, then please do get in touch. And we're particularly interested in capturing others' experiences of using it. We're just really on the journey of use cases. And we know that the expertise within your community is going to further contribute to developing this work. So if you'd like to use it, yes, please do. Please get in touch and provide us with some feedback. It sort of also links to the question around support to use it. So there is another set of resources behind this tool, and we also have developed skills within our teams to provide support in the way that Ellie described. So I think I just encourage you to have a conversation with us, but yes, please take away these resources, and if you have some use cases, then let's get using it and learning from it. Anything else, Emma?
I'm just having a look at questions. There are some great comments as well. I'll just say Jen's great comment. So it makes me wonder about the skill set of spotting patterns that are no longer serving and creating new patterns of behaviour that need to be created. So, actually, there is a question again. Sorry, Jen. What is the role of data analysis and insight to spot and track those patterns? I'll come with that question, then another one's following.
Andrew, can I pass that one to you?
Hi, thank you, Jen. Yes, a really interesting question. I suppose there's some guidance through the Choosing Wisely initiative and through the NHS EBI programme, because both of those major national initiatives have provided guidance on how to spot low value care. And so that might be a way to identify the kinds of things that you might like to consider for stopping. In terms of the role of data, and it's critical, I think, as part of our pillars and part of the model, that the decisions to stop, and then the decisions about and understanding the impacts and consequences of that should be based as much as possible on available data. If there's a need to do real-world evaluation around this before fully deciding to de-implement, then that might also be justifiable to really understand the ripple effects. Does that help? Or would you like to come back on that one?
Yeah, no, thanks. That's really helpful. Thank you very much.
And a great question from Elizabeth. Can I ask, how can learning from what we remove or stop doing help build more effective future-proof implementation?
So I think there are important links between de-implementation and implementation, if only because often they're being done in parallel. So I think implementation of an innovation or a new intervention will be most effective if the old way of working is stopped in a managed and considered way. So I think the learning comes from the interplay of de-implementation in parallel with implementation. But as we've highlighted, we don't think one is the reverse of the other. I think what came through really strongly in our work was the importance of the behavioural change, attention to behavioural change in the de-implementation space. And that, as we've talked about a lot today, around the need to pay attention to de-implementing something with dignity, celebrating its past, and making sure that future implementation takes that history into account and learns from that. So I think it's that interplay between the two that's so critical to watch for learning.
Great. And Helen also came back with a sort of response to Elizabeth, which I think is great, is that we'd hope that all new processes are designed from a point of identifying what doesn't work. So yeah, I think that's a good comment. I think we are at the end of our list of questions. I don't know if anybody has any hands up. Oh, we've got Helen. Oh, Helen, I think you're on mute.
There we go. It wouldn't unmute. Sorry about that.
Hello.
I thought I'd go for it. I've come along today to sort of like absorb the discussions and reflections on, you know, how to go about de-implementing. I think some things are too large and too complex to even contemplate de-implementation. But I'm certainly using the content to figure out how we ask to run something parallel to prove that one way of working is actually better than the other, and then in the long term create some emphasis to move over practice to, you know, a new understanding. I'm talking about weight management and working without surveilling weight to elevate health literacy and health outcomes. But yeah, I think any reflections on, you know, do they call it how to eat an elephant? Which parts to try and impact first? You know, the lower tiers of the system, or the, you know, the general understanding of what not's working. We're doing a bit of all of these, but yeah, I just wanted to got any reflections on that, please.
So Helen, I think possibly there are two things. I think one is that there's a whole body of literature around how to decide what to stop and how to identify what is often referred to as low value interventions. But that literature isn't something we've brought in here, but there are a lot of frameworks to do that. So if your interest was in how to go about prioritizing what to stop, that is there to look at. I think otherwise within practice, I think it's really helpful that you raise the question of complexity in terms of where to start. And actually you might, when we were having conversations with Ellie in NHS Dorset around their case study, that felt like a really nice place to start, because they had a very clearly articulated journey, a very clear focus for what they wanted to de-implement and where they wanted to get to, actually within a very short space of time. So that was an ideal use case actually for this type of very systematic managed approach. So there were, I think, some benefits in starting with something very well articulated and with a really clear outcome.
Yeah, thank you for that. Just a follow-up comment as well is that, so we've at Intrui, we've done a lot of what I call do with work. So I think it's known in the system as PPIE work. So starting any and grounding any new processes and innovation in feedback directly from the people who will most impact. But yeah, so I think that's a key foundational part of any change work, isn't it? And QI work is around basing it in. Yeah, but and also I think I highly regard the workforce itself as part of that PPIE process. You know, I don't think it's just about patients, it's about the workforce tasked to deliver as well.
Absolutely, and pillars 1 and 2 of the model would absolutely do that work with the people who are affected by the change. Just ask for some brief feedback. So Jen, can I come to you first?
Sure. Yeah, we had a group conversation, and it was looking at what did we learn. There's some examples of projects that are soon to be and some existing experience. I know Claire has her bowel screening program coming up, and it's just a big question like, how do you build in sustainability? How do you write it in? That was a similar reference that Lawrence had with his clinical pharmacy work. So how do you write in and build in adaptability and sustainability from the outset, and almost see this as not starting one thing or stopping the other as such, but it's an evolution of a process. So that was a key theme. And then how do you bring staff along with you if there's, the barrier and resistance to change, and maybe helping them think about the outcomes and their role in that. But nevertheless, it is a barrier and change, especially when you have that kind of group think and fear of change. And one way to kind of end with dignity is just to really involve people the best and as broad and deep as possible. So yeah, and involve everyone and invite input. So those are the highlights from us.
Great, thank you. Spiller?
Yes, hi, thank you. We had good conversations with Christopher, Heather, and Marta, recognizing there will be lots of change in healthcare, particularly when it comes to digital, to AI, as well as to kind of responding to various challenges that get raised, and the real importance of kind of having trust and confidence, both kind of in leading that work and building that within the staff as a key way to obviously move on to something else and being able to implement that. We spoke about the importance of thinking very carefully of what's the best use of the resource that there is available, recognizing that it is kind of an additional load for staff and that can be challenging in the current context. And how important the ethics are in the implementation, and they're really kind of taking that time to pause and reflect, which too often gets missed, or the speed of the change that is required doesn't allow for some of those really important aspects sometimes. So it's important to pay attention to that.
Thank you. Great points. Anandita.
Thanks, Philippa. I was lucky to have a bit of a one-to-one conversation with Elizabeth, who kind of works as an education lead. So we talked a little bit around kind of a program that she runs around supporting people to think about how they stop projects, and the kind of word reduce came up a lot in terms of like the things that she sees around how people are kind of approaching the 4 Rs, and being an education lead, we kind of then focus a little bit on the skills, so like what's needed to really focus on the implementation, and the fact you've covered kind of already how it needs compassion, but as does implementation, but like a slightly different lens, and really thinking about how you engage with people, and the need to kind of be quite kind of bold, brave and resolute, and really hold the evidence base around the change possible. Kind of as Srila alluded to on conversation, it's really challenging for kind of practice professional, groups to kind of think about changing and from their kind of established ways of working. So and to undo that and then reestablish kind of a new way, so kind of people do hold on to those things. So actually the need to kind of really present that evidence and bring people with you, and actually recognizing that it probably needs more energy and drive than maybe implementation does, where you kind of might search for the energy that is out there in the system, and you don't always have that with kind of the implementation. Thank you.
Great, thank you. So I'm scribbling away because it's such interesting points. Thank you very much. I'll go to Emma next.
I'm afraid to say that I didn't have anybody in my group, Philippa, so because so many people were really busy moving on to their next thing, so I won't have any feedback for you.
Thank you, no problem. It is busy out there, and it's also lunchtime, isn't it? Andrew?
Hi, Philippa. Yes, so I had a couple of colleagues on the call. One was on a train, so we did it all by chat. But in terms of had they been involved in de-implementing previous ways of working, yes, both. One lady on the train mentioned that she's been involved in lots of small change and attempts to stop things, but actually has been deeply frustrated by that experience, and it's exhausting, in her words, to not be able to stop old ways of working, and it's an interesting reflection and about that exhaustion, and whether more thought to the plan and more thought to the frustrations, could some of this might be addressed through a managed process and through some of the mechanisms we talked about today. And in terms of the other question, in your experience, what might have been the strategies or for helping things retire with dignity? The other colleague highlighted that just thinking about that concept, the idea of retiring things with dignity in itself is beneficial and a really effective way to view the situation, and rather than attempt to layer on more and more and more onto our busy, capacity-stricken colleagues. That really considering how we can help them move away from old ways of practices, but also do that in a managed and careful and respectful way. Thank you.
Thank you. Patrick.
Hi, Philippa. Similar to Emma, I didn't have anybody initially in my room, so I was lucky enough to be redirected into Jen's room, who you've already heard from.
Great. And I'll just finish then. We had an interesting conversation. So colleague in our room hadn't experience of doing de-implementation, but had an example of an area where de-implementation would be really important around a shift from analog reporting to digital reporting, and particular use of AI in her area of work. So we identified that was a really well-defined area for potential use of a de-implementation approach, and talked a lot about the importance of engaging people in that process, which has already started in their workplace. Okay, so thank you, everybody. We shall finish the session. Just to wrap up, what we'd be grateful to hear from you is just some final reflections in the chat. So if you could put in the chat, please, one thing that you've learnt today. We'll just give a couple of minutes for that. So shout out for the 4 R's. Thanks, Matt. We must let you know that that's from a referenced paper in the slide deck. So we can't claim originality for describing those, but yes, they're useful. Retire with dignity stands out. Yeah. It's great to hear that you feel there's values underpinning this model that are compassionate and caring. Jackie, you ask, is there any quantifiable evidence about the time needed to do this, i.e. help with getting leader support? Not that we've collected. I wonder though if Ellie would mind coming in on that as to the time required.
It's difficult to say on the timings, I'd say, but what did help though is having had all this information from the canvas, we were able to then use a lot of that to put into business cases that we had to take through governance routes, because I find that that's the time issue in my area of work. I don't know about everybody else, but to get approval to do a lot of stuff, you have to have all of the evidence behind it. And this, we could just pick it up off the canvas and put it straight into the documentation. So that really did streamline some of that work.
Thank you. Okay, and just a question about how to get in touch if you'd like to use it. My details and Emma's details are in this slide here, and we'd be delighted to hear from anybody. There's also a link to more information about the work on the Health Innovation website, Health Innovation Wessex website. Okay, I will hand back now to Matthew to close the session. I hope you've all found it helpful, and thank you so much for joining us.
Yeah, great stuff. Thanks so much, Philippa. Yeah, and a huge thank you to all of the speakers. Really fantastic workshop. I think brought a lot of clarity and rigor to this topic. You know, as Andrew said, there's kind of a lot going on that you know, is right for kind of de-implementation. The stakes are quite high. I think if we get it right, we can save a lot of money, you know, and really drive value and increase quality as well. And really important to make sure we're contributing to all of those objectives. Great stuff. So yeah, huge thank you to colleagues from Health Innovation Wessex, Philippa, Andrew, Emma, and Patrick. And also, yeah, massive thank you to Ellie from NHS Dorset. Really, really interesting to hear your experience of putting it into practice, and that really brought the 4 pillars to life